I'm Rod Rourke, and I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, everyone, and welcome to the January 2017 edition of the PRS Journal Club podcast. I'm Shuja Shafqat, PRS resident ambassador from Lehigh Valley, and I'm joined by my co-ambassadors Jordan Frey from NYU and Chad Purnell from Northwestern. Today we have the honor of being joined by Dr. Maurice Nahabedian, professor of plastic surgery at Georgetown University. The article we'll be discussing next is Late Surgical Site Infection in Immediate Implant-Based Breast Reconstruction by Dr. Sina, Pusick, Wilkins, and Chun. Again, remember that all these articles can be read for free on prsjournal.com, including an archive of all past Journal Club articles. So thank you, Dr. Nahabedian, for joining us for this article.
Thank you for having me.
The goal of the authors in this paper was to look at the incidence of early versus late surgical site infections in immediate implant-based breast reconstruction, and also to identify any patient risk factors for late SSIs. So this was in light of observations that many surgical site infections occur outside of the 30-day postoperative period, and that the larger databases such as NSQIP or TOPS may be underestimating the infectious rates in these patients. So the authors looked at 1,662 implant-based breast reconstructions, which were all immediate, in 1,024 patients, of which 1,491 were traditional two-stage tissue expander and implant reconstructions, and 171 were single-stage direct-to-implant reconstructions. They grouped patients overall by overall surgical site infection, early versus late, major versus minor, and looked at multiple predictors for late SSI. They defined early SSI as within 30 days and late SSI as between 31 days and 1 year. They also noted that for the traditional two-stage expander to implant reconstruction that they followed the patients for 1 year after they were exchanged to a permanent implant. They also defined minor infections as SSIs treated with only outpatient oral antibiotics versus a major infection which required hospitalization with IV antibiotics and possibly operative intervention as well. So their overall surgical site infection was 9.9% in direct-to-implant, 7.7% in first-stage tissue expander placement, where around 50% for both were defined as late infections or categorized as late infections. Major surgical site infection was 6.4% in direct-to-implant and 3.4% in first-stage tissue expanders, where again about 50% were in the late infection category. And minor surgical site infection was about 3.5% in direct-to-implant and 2.3% in first-stage tissue expander placement, where, again, about 50% for both were late infections. When they compared direct-to-implant and first-stage tissue expander reconstruction, they didn't find any statistical difference in overall major or minor SSIs. However, when they looked at the second-stage exchange for tissue expanders to permanent implant, they did note that significantly more second-stage exchange surgical site infections were late at 71%. When they looked at explantation of these devices, significantly higher number of late surgical site infections required removal of the implant, and then about 50% of direct-to-implant, 64% of tissue expanders, and 100% of second-stage exchange explantations due to infection were all due to late surgical site infections. They also identified radiation, and then they specified that it was only radiation after the first stage tissue expander placement, and increased BMI as significant predictors of late infections. In their discussion, the authors talk that since a majority of infections occur late, incidences in these larger surgical databases may not be accurate, and they mentioned two other studies in their discussion that show that late infections are more common. They also discussed why that may be caused. They did identify biofilm as a possible cause of late or chronic infections. And then they go on to discuss radiation and BMI as predictors for late infections, which is something we know from the literature, from multiple other studies, and from our teaching that these factors predict for risk of SSI overall. But again, in this paper, they looked specifically at how they predict for late surgical site infections. They do mention some limitations to their study, most notably the variability in patients, especially what I noted was the duration of antibiotic treatment and their specific treatment protocols for infections. So I'll turn this discussion over to the group, especially want to hear what Dr. Nahabedian says. Again, with a paper that talks about risk factors and predictors for certain complications. Again, I'd like to hear from somebody in your experience, how does that change your counseling or management of your patients?
I think this is an excellent paper. I mean, this is all part of the Mastectomy Reconstruction Outcomes Consortium that was spearheaded by Ed Wilkins and Andrew Fusick. And they basically studied these patients over a 5-year period prospectively. So I think that the data is very strong and it's very valid. Honestly, I think there's a lot of confirmatory information here. And I say that because, I've kept a database for years and years, and I've tracked infections. And I published a paper, 12 years ago, and the incidence of infection in that cohort of patients was about 7%. And interestingly, the majority of the infections were after 30 days. So there were 10 patients that had infected devices, and 9 of them were infections that occurred greater than 30 days after it was inserted. The majority of those were tissue expanders rather than implants. But it was interesting how this study kind of confirmed that there is a high incidence of late infection. The other thing is that this study confirms that radiation is a cause of infection, and there has been some debate because some studies have shown that radiation doesn't lead to infection. My experience is that it does, and this confirms it. BMI, another factor that leads to infection. I like the fact that they said that for every point increase in the BMI increases the SSI rate by 8%. I think that's a really good number to be able to tell patients. So if you've got a patient who's got a BMI of 35, there's probably a much higher chance that they're going to get an infection based on some of these numbers that they've been able to generate. So I think that this is a very, very good paper. It's good because these are experienced surgeons who understand what they're doing, and I think that the complication rates aren't extreme. They're not 20% or 30%. And I think that people who have infection rates that are that high need to really think about what they're doing. The other important thing in this was that they found that ADM did not increase the rate of infection. So it was not a significant factor when analyzing infections. So I think that's also useful information.
Yeah, I agree. I think that every 1 point for BMI increases the risk of infection by 8% is interesting, because that's definitely something that if you tell a patient, it's a very realistic statistic to kind of understand, and it would be easier for some patients to understand as opposed to quoting a lot of numbers. This may be a somewhat off-topic question, but especially when talking about increased BMI, I think that trying to counsel the obese breast reconstruction patient is always a challenge, knowing that their obesity increases their risk of surgical site infection, and certainly this paper tells us that it increases their rate of late surgical site infections, which also points us in the direction that that may require explantation or maybe a major infection. How do you counsel the patient with an elevated BMI with regards to implant-based versus autologous-based, and then immediate versus delayed reconstruction? I always find that that's kind of a struggle sometimes to understand that algorithm.
The proper way to counsel patients is to let them know that when their BMIs start to get above 30, that they are at higher risk for infection. Now, the gray zone is not real well defined, and all the patients are a little bit different. And body characteristics are a little bit different. Some patients with a high BMI carry their weight maybe at their hips or in the gluteal region and maybe not in the chest area. So you have to individualize each of these patients. So my kind of strict cutoff for BMI is really kind of approaching 40. And what I do is I will assess the skin and the soft tissue thickness and just make sure that even if I put in a large device, it's not going to get buried into that thick subcutaneous layer. So I tell patients about those risks. Now, I also tell them that if they've got other comorbidities in addition to the obesity, maybe it's poorly controlled diabetes or maybe hypertension or maybe they smoke, then they're getting into risk factors that really negate me being able to successfully perform immediate reconstruction. I tell them that they have to stop smoking, they have to optimize some of their circumstances and comorbidities, and sometimes it's better to do a delayed reconstruction. Frank Izek did a study years ago demonstrating that delayed reconstruction will reduce your complication rate by 50%. So the things that delayed reconstruction will do for you is the skin flaps can heal nicely, you can open up a space and you don't have a lot of dead space and room for seromas. and you're not going to have skin necrosis on a delayed setting. So all of these things are beneficial to the patient. So I tell them that. I just basically say, listen, we can do this, but we might not do it immediately. I can reduce your complication rate by 50% if I do this on a delayed basis.
That's a great statistic.
So sticking with the topic of risk reduction, this paper showed that radiation therapy increased late infections by an odds ratio of 4. So whenever you're counseling patients who are going to be receiving radiation, what do you recommend for those patients, especially patients who are going to be receiving radiation and also have other comorbidities such as obesity and smoking?
That odds ratio of 4 is right on, because in the study that I did a few years ago looking at radiation, it increased the risk of infection by an odds ratio of 4.6. So it's right on with my experience. So I tell patients that radiated expanders or implants are going to have a higher complication rate. And that complication rate, surgical site infection being one of several complications that can occur. But I'm honest with them. I tell them if you're going to get radiation, the likelihood of a long-term complication is going to approach 40%. You add up capsular contracture, incisional dehiscence, seroma, infection, premature removal, it adds up. So I'm very honest, and I tell them that these are the risks associated with radiation. Now, that doesn't mean I won't do it. I give patients a chance. Some patients aren't good candidates or don't want an autologous reconstruction. I don't like autologous reconstructions that get radiated. I always want to do a flap after the radiation. I think there's aesthetic reasons for it, and I think there's also some oncologic reasons for doing that. But that's kind of how I counsel these patients. Even though they're going to get radiation, I'll still go forward and do a prosthetic reconstruction. They just have to be aware of those risk factors. I think as long as you tell them the risk factors and set the expectations, then there won't be any surprises. And it needs to be well documented.
And Dr. Nahabedian, taking this one step further, when you have a patient with an implant-based reconstruction who does have a late surgical site infection, what is your algorithm in terms of salvaging the implant or going to the operating room, replacing the implant, removing the implant? How do you approach that?
If somebody comes in with a late infection, it's going to depend on if they're radiated or not radiated, and it depends on what the quality of the skin is and how erythematous it is. So typically what you see with infections is pain, swelling, and redness. Fevers and white blood counts may not be elevated. It's only elevated in about 30% of patients. So if it's just mild, I'll start them off on a course of oral antibiotics and see what happens. If it doesn't improve, then I'll probably bring them in and start them on intravenous antibiotics. If it still doesn't improve or it deteriorates, then I take them back to the operating room. If there is ongoing infection, if there's purulence, everything comes out. I don't really try to salvage it. I come back 6 months later or 3 months later in some situations and perhaps consider putting in a new device. In some situations where there isn't gross purulence, you can try to salvage the reconstruction, but I always take out the infected implant. I may really irrigate that pocket, scrub it out, take a curette if there's any biofilm, and just really clean it out. And I'll give them another chance at an implant reconstruction because it's kind of a devastating event if, you lose the device. So, at this point, I'll give them another chance and maybe put in another device, but only if it's not terribly infected. And it's hard to quantitate. A lot of it is just kind of that feeling when you get in there and you look at it and you say, I think I might be able to try to salvage this. But if it's really bad, gross purulence, I just take everything out and close it up and come back another day.
And just as a quick follow-up to that, if you take a patient back and let's say that you're going to attempt a salvage even though you've taken them back to wash them out, at that point, do you change the devices that you're willing to put in? Here at this institution, we tend to move to only smooth round implants with a drain placement at that time. Are you still willing to place, say, a shaped anatomic textured implant, or is it only smooth round at that point?
No, I would probably change the device. If it's a shaped device that gets infected, if I was going to replace it with something, I'd probably do the same thing and put in a smooth round device. And I would always put a drain back in, and I would keep them on antibiotics for an extended period of time. So I think in those situations where salvage is the goal and it's what you're attempting, then I think you have to kind of go beyond skip protocols and place drains in for a longer period of time, use biopatches, and really watch these patients carefully. The last thing you want is kind of a recurrent infection early on. But, bacteria can hide. One of the scary things about organisms is they can lay dormant in scar tissue, and then maybe it's a warm weather event, or the patient's out doing something and real active, and all of a sudden an infection can come back. So, they're never quite out of the woods. And some patients can seed their devices. I mean, maybe it's dental work, or they get a pneumonia or a urinary tract infection. Bacteria gets in the circulation, and then it may seed the surface of the device. And I think textured devices may be more prone to seeding because of the way the scar is. So anyway, those are all just some thoughts.
I think it's interesting to talk about people's protocols, not for infections, but for perioperative prophylaxis. The October PRS Journal Club delved into that with a systematic review of protocols for perioperative antibiotics. So in your experience, or what is your normal protocol? Is it just perioperative? Is it, when the drains are still in and then you discontinue antibiotics when you remove the drains in your first stage reconstructions? Or is it kind of a set number of days that you keep people on antibiotics postoperatively?
Traditionally, what I used to do was I would keep patients on antibiotics until the drains came out. And the drains would typically stay in anywhere from 1 to 2 weeks. Having reviewed a lot of the literature and having a good understanding of skip protocols and antibiotic resistance and some of the problems we're encountering with some of these organisms now, I've kind of tapered my approach. So what I do now is I'll give patients preoperative antibiotics, usually about a half hour before we start anything. And it's usually Ancef, and if they're allergic to something, it might be Clinda or Cipro. Postoperatively, these patients are usually in-house overnight. We'll keep them on IV antibiotics, usually Ancef or whatever it is we gave them preoperatively, and then they'll go home on antibiotics. And I keep them on home antibiotics really for about 3 or 4 days, and that's it. So they come back the first clinic visit. If everything looks good, I just stop the antibiotics. The drains stay in, discontinuing the antibiotics. And a lot of it is based off some of the literature that I've read suggesting that if you give at least 2 days of postoperative antibiotics, you can really decrease the amount of postoperative infections. Now, skip protocols, Brett Phillips did his systematic reviews and basically found that whether you do skip or non-skip, the infection rates were the same at about 5.9%. I don't know, that hasn't quite been my experience. I err on the side of caution, and I just feel that many of these patients have cancer, they have some immunosuppression, they've got foreign materials and compromised tissues, and we're using biologic matrices. I just, for the patient's sake, keep them on antibiotics for at least a couple of days. But I do believe you can stop them at an earlier stage than waiting till the drains are removed.
This may be a controversial topic, but do you see any indication for patients to go home on prolonged IV antibiotics, whether you're attempting to salvage an implant or you've taken the patient back to the operating room and washed them out and placed a new implant? Do you see any indications? Do you ever send people home on prolonged IV antibiotics at home, or is that never a consideration for you?
So sometimes if a patient comes in with a real raging infection, they've got big-time cellulitis, they've got an elevated white count, they're having fevers, we'll get an infectious disease consult. Oftentimes, those patients will try to cool them off with IV antibiotics for a day or two before we take them to the operating room, and many times they're getting PICC lines because the infectious disease doctors want to keep them on IV antibiotics for anywhere from 2 to 4 weeks. And honestly, I'm okay with that. So it's not common, but we do it on occasion where we'll send somebody home after a nasty infection with IV antibiotics for at least a couple of weeks. But it's more of an infectious disease recommendation.
Well, I think with that, we'll end our discussion of this article. Remember, everyone, to tune in to the other 2 articles that we'll be discussing this month on the podcast, as well as the PRS Journal Club podcast that we broadcast every month. And then don't forget to participate in our monthly Twitter hashtag PRS Journal Club, where we'll be able to interact directly with this month's selected authors and ask them questions and discuss their articles further. And I would just like to say thank you again, Dr. Nahabedian, for joining us and giving us your expertise on these topics.
Thank you very much for having me.